Hello everyone, very good evening to all of you, and today I am going to discuss about those recall questions which had been asked in INICET May 2022, because these questions and these topics are very important for upcoming future exam also. This question was well balanced, and I think very good proportionate amount of question came from the pathology, and many questions were from my notes and from my book also. So I will request you all to just follow my Telegram group and my YouTube, right? These are the QR code you can scan right now from your screen, and try to follow important information which I am giving you on my Telegram, or I am discussing anything on my YouTube, especially my high yielding shorts which I usually discuss, right? So that is very important. Keep watching all those things. So let's start. So it is a recall based. Maybe some of the questions had not been recalled properly by me also, and I would like to ask you to post your comment in your in this comment box if there is any necessary changes or modification is required, and I will definitely come up with the shorts. I will make high yielding shorts for those topics, and these topics which I'm not going to discuss very detail in this particular discussion, I'm going to make a very good amount of discussion in the form of high yielding shorts. So please subscribe my YouTube channel and share with other friends also, so that your juniors and your friend can also get benefit from this. So let's start. So question number 1 is, which of the following is not true about inflammatory bowel disease, right? Skip lesions are seen in Crohn's disease. So now you tell me, what should be the right answer? Skip lesions are seen in Crohn's disease. So is it a true statement or false statement? So first of all, we will know that this is a true statement, right? So this is a true statement. Skip lesions are seen in Crohn's disease, right? Inflammatory bowel disease may be genetically associated. What do you think? Is it genetically associated? So answer is yes. If you look at the Crohn's disease, as I have told you in my classes also, they are associated with NOD2 gene mutation, right? So Crohn's disease is associated with NOD2 gene mutation. So yes, they are having association with genetics also. So this statement is also a true statement, right? So we can say that this is also a true statement. So the second is also true statement. Crohn's disease is a mucosal, and ulcerative colitis is transmural histologically. So what is this? So what I will say that Crohn's disease, if you look at this, Crohn's disease is transmural, right? And ulcerative colitis will be the mucosal or submucosal involvement. So this will be the true statement, right? So what I am writing in this statement is not true. Mucosal is not, it is not transmural, right? So what I will say, it is a false statement. Crohn's disease is completely curable. Crohn's disease we cannot completely cure, right? So they will have a recurrences. So that is also a false statement. So what should be the correct option for this question? So answer should be B, 1 and 2 only, right? So you can see answer is B, 1 and 2. So as I have told you, Crohn's disease, if you look at the Crohn's disease presentation, they are involving all the layers: mucosa, submucosa, muscularis propria and serosa. That is why we are saying that Crohn's disease is a transmural disorder, whereas ulcerative colitis, you can see only mucosa and submucosa is affected. So only mucosa and submucosa will be affected, or ulceration will be present here. And if you look at this histology, you can easily make out if it is transmural, so there will be more chances of perforation in Crohn's disease, right? More chances of perforation, more chances of peritonitis will be in case of Crohn's disease, right? So these are some extra information we should remember. Now coming to the next question, this is again a question which I have discussed in my app lecture also. If you have gone through my app, so this question is, you can see here, a 2-year-old male child admitted with recurrent bloody stools. So here you can see the hint, male child, recurrent bloody stools. On examination, he was having petechiae and dermatitis like rashes, right? TLC was normal, but platelet count was 20,000 per mm cube. What will be the next best step to confirm the diagnosis in this case, right? So male child, platelet count is decreased, rashes and dermatitis. When you see in this 2-year-old boy, so you will suspect about which disorder? Which disorder you will suspect? Immunodeficiency disorder, Wiskott-Aldrich syndrome. right? So we are having suspicion for Viscott-Aldrich syndrome. So what you will do to confirm the diagnosis, this is the question. So will you do the LFT in this case? So probably it is not required. Bone marrow aspiration is also not required. Antiplatelet antibody assessment is used for the immunogenic thrombocytopenic purpura, not in this case, right? So in this case you have to analyze for the VASP gene. So this should be the correct answer, right? So I will just give you a brief account of this Viscott-Aldrich syndrome. If you have observed that what I have said in the question, right, this is a male child, right? So why male child? Because it is a X-linked recessive disorder and males are more commonly affected. So that is what number one hint was given in the question itself, right? So that is how you have to perceive that it is a X-linked recessive disorder. So Viscott-Aldrich syndrome is a X-linked recessive disorder. So male will be commonly affected and male boy was there. And what will be the symptoms? So here you will be finding VASP gene mutation. So remember, gene sequencing will be done to confirm the diagnosis where VASP gene mutation will be present, right, which is required for cell migration and signal transduction, and when they are deficient, so these two things will be decreased. And what will be the finding in these patients? So these patients will be having thrombocytopenia, then they will be having eczema, and then they will be having recurrent infections. So this we can remember by a mnemonic which is called as water, right? Va is VASP gene, T is thrombocytopenia, T is thrombocytopenia, right? E is eczema, and re is recurrent infection. So that is what it was given in the question also, right? So now you can see on clinical examination, you will notice they are having eczema, right? So you can see eczematous lesions are present on the back of this kid, and on general examination you may notice petechian purpura, and in platelet you can see these are the normal platelet, right? So this is the normal slide. Normal platelet will be bigger and very dark in color like this, but here you can see only few platelets are there, and these platelets are also very small. So these are small platelets or microthrombocytopenia. So not only the thrombocytopenia, they will be having a small platelet also and decreased platelet count also. So both will be present in the Viscott-Aldrich syndrome. So answer was VASP gene analysis. This was a very simple straightforward question. It's a physiology question also, right? And in my app also I have discussed about this thing, right? Blood level of 125 dihydrocholecalciferol is positively regulated by, so this is positively regulated by hormone called as parathormone, right? So this is parathormone, parathyroid gland, right? That's all. Next question is, iron is transported by which carrier protein into the enterocyte? This is again a very simple question. In my classes I have discussed so many times, right? Okay, there is a divalent metal transporter which is a non-specific protein, right? So it is, question is, so you have to think about what is the language of the question. As I always say that iron is transported by which carrier protein into the enterocyte. So try to understand what is the question. Question is about into the enterocyte, within the intestinal epithelial cells. So it's not transferrin. Transferrin will be taking them from the serum to the bone marrow, right? Enterocytes, who will be taking it, is a divalent metal transporter 1. So answer should be this one, divalent metal transporter 1. Right here I will show you this picture, divalent metal transporter. It will not only for the divalent iron, it is also for the copper, also for the harmful element like a lead or cadmium. So by showing all these names, what I want to show you, I just wanted to show you that these are non-specific protein, right? So DMT1 will transport them. So what is DMT1? Because they are allowing all of them, so this is a non-specific protein, right, which is non-specific carrier protein which will allow iron, not only iron, any divalent metal it can transport. That is why the name is divalent metal transporter. So now you understand why this name is divalent metal transporter, because all divalent metal will be allowed. So this was also AIMS question, right? Ferroportin, what they will do, they are, see, this is the apical part of the duodenal cells and this is the basal part of the duodenal cell. So apical part will be having DMT1, basal part will be having hephaestin and ferroportin, right? So here you have to remember that ferroportin will take the Fe2 plus from here and this will transport it to hephaestin, right? And hephaestin will convert Fe2 plus to Fe3 plus, right? So ferroportin is just transporting, hephaestin will convert ferrous to ferric. And remember, this hephaestin Similar function of heparin is also performed by ceruloplasmin. So please remember, because this was also AIMS question. So ceruloplasmin was a question in AIMS exam. So we must remember this point, that ceruloplasmin is also involved in ferrous to ferric conversion. So please remember, two hormones which are involved, two enzymes which are involved, heparin and ceruloplasmin, both are ferric oxidase and both will be converting ferrous to ferric. Please remember, ferrous to ferric conversion is done by heparin also. I'm just marking again, ferrous to ferric conversion is done by heparin also and ceruloplasmin also. Both can convert ferrous to ferric. Then third thing is, who will inhibit ferroportin? So please remember, hepcidin will inhibit ferroportin. This was also question in AIMS exam, right? So who will inhibit ferroportin? So it is heparin which will inhibit ferroportin. That was also question in AIMS exam. So these are the questions which had been already asked in exam, so they may repeat this in NEET PG exam also, right? So now for this particular question, non-specific protein divalent metal transporter will allow this iron movement into the enterocyte. So this is the enterocytes which had been shown here. So who is going to allow them inside the enterocytes? So it is divalent metal transporter 1, right? So moving on to the next question. All of the following are AIDS defining malignancy. This is a repeat question of AIMS and many times I have discussed in my lecture also, right? So AIDS defining malignancies are, remember, it is NHL, it is invasive cervical cancer and Kaposi sarcoma. These are the three malignancies which are the AIDS defining malignancies, right? That's all. Whatever is remaining, this is not AIDS defining. So answer should be melanoma, right? Now coming to the next question, again it was discussed in the app lecture. A 10-year-old boy came with complaints of knee joint pain and lesion in hand as shown is given below in the image. So likely diagnosis, so you can see here what I'm showing you, these are all the rashes which are Gottron's papule, and this Gottron papule is diagnostic of dermatomyositis, right? So you can see in dermatomyositis there are two important findings which we will see. Number one is heliotropic rash. So you can see these are the heliotropic rash. What we are observing here, there is a purplish color or lilac color or red color lesion around the eye with swelling. So periorbital swelling plus red or purple color lesion is seen, that is characteristic of the dermatomyositis. This is called a heliotropic rash. And now you can see this is the another thing which I have shown you. This is the Gottron's papule, right, which is the erythematous scaly papules which will be seen on the knuckles, or it can be also seen on the elbow. So this is Gottron papule, and this sign is also known as Gottron sign, right? So this is also called as Gottron sign, which is seen in dermatomyositis. Next question. This question is little controversial because I am not getting the exact picture, but many students were telling that there was a picture which was showing you epithelial pearl. What I feel that would not be epithelial pearl, that would have been a chondrocyte, which looks like a epithelial pearl to you people because you are not aware of that thing. So if anything is feedback, you can send in my telegram, so what image had been asked, or you can post here also. So now this question is a 75-year-old male patient with joint pain, knee joint pain. Biopsy was given like this. If biopsy was given like this, which I have got feedback from one of my student, so if this biopsy is very characteristic of osteoarthritis. So please remember, this is a very characteristic of osteoarthritis. So TB synovitis, you will see granuloma you will find. So we are not seeing any granuloma. You will find giant cell, which is not seen here. In rheumatoid arthritis also you may see the granulomatous lesion and giant cells, which is not seen here, or you will be seeing the necrotic area, which is not seen here, right? Lyme's arthritis, you will see inflammatory cells, but here we are not seeing any inflammation. See, osteoarthritis is not an inflammatory disorder. You will not find inflammation. It's a degeneration. So you can see these are the chondrocytes which are showing you the fibrillar appearance. So this fibrillar appearance is diagnostic of the osteoarthritis. So that is why we are thinking osteoarthritis. So please remember why osteoarthritis I am thinking, because it is showing fibrillation of the articular cartilage, which we are seeing here, right? So all these are fibrillation of the articular cartilage which we are observing. That is why we are thinking in terms of osteoarthritis. And remember, this is the most common type of joint disease in older individual, and age group is 75 year, right? And remember, as I said, it implies inflammatory disease, but it is considered to be a degenerative disease of the cartilage. So you're not going to see much inflammation here. You will be seeing degeneration of the cartilage, which is giving a fibrillation of the articular cartilage, right? So most probably answer should be your osteoarthritis. Again, a very important and repeat question from the previous aims. Identify the cells stained with the toluidine blue stain. So we all know that toluidine blue stain is used for mast cell, and all these are mast cells which are toluidine stain positive. So toluidine blue stain is used for mast cell, right? Coming to the next question, which of the following is a marker of natural killer cell? I really say that in my lecture I used to say that natural killer cells are CD16 positive and CD56 positive. So you might be searching about 16 and 56, but you did not get. But don't worry, you should not worry about these kind of 1 or 2 questions examiner will ask. That does not mean that you start mugging up all the CD marker. That's all. It has been asked, so now you remember CD94. You need not to remember each and everything, right? So here I will tell you one by one what will be the right answer. CD3 is a marker of T cell. CD25 is a marker of interleukin 2 receptors. CD68 is a marker of macrophage and histiocytes, right? Macrophage and histiocytes. So you can see this in Langerhans cell histiocytosis. And CD94 is the marker of natural killer cell, right? So this is the correct answer, right? So answer should be CD94. Here I would like to tell you if the things are written here, so I will just emphasize CD94 is a NKG2 receptor, right, which is a C-type lectin receptor present on the natural killer cells, and this is not only on the natural killer cells. So please remember this point. CD94, you have to remember, it is not only the natural killer cell, it can be present on CD8 cytotoxic cell also. So please remember both the names. So mostly it is, or predominantly it is natural killer cell, but it can be also seen on CD8 cytotoxic cells. That is what it is saying, that, right, it can be present on CD8 cytotoxic cells also, as well as natural killer cells also, right? Coming to the next question, which of the following is correct about anemia of chronic disease lab diagnosis? So what will be correct in anemia of chronic disease? So anemia of chronic disease, ferritin is storage, storage iron. So storage iron is usually increased, it is not decreased, it should be increased. Iron stores are depleted. Iron store means ferritin only, right? So iron store means iron storage is in the ferritin form, so it should be increased, right? Iron storage form should be increased. Transferrin saturation is decreased. See what is happening, what is transferrin saturation? If you look at the iron level, the ferric level is high in the bone marrow, right? So that is what I said, serum ferritin will be high. And in this anemia of chronic disease, what you will understand, that storage iron is, which is having Fe3 form, is very high, or you can say this Fe3 will be present in ferritin form, more specifically, is very high, right? So bone marrow is saturated. So what will be the requirement of the iron from the blood? So it will be less. So there will be less amount of transferrin, right? So there will be less amount of transferrin. So if transferrin is low, so TIBC is also low, because TIBC is total iron binding capacity, right? And here you have to remember that serum iron level will be low. Serum iron will be low, or you can say that serum Fe3 plus level will be decreased. So because of this, what will happen? That percentage saturation of transferrin will be decreased. So percentage saturation of transferrin will be decreased, right? So here I will say that there are two things which can be correct here. One is percentage saturation of transferrin is also decreased if this was a multiple choice option, or it can be if it is given in the question as a increased, then it will be a wrong statement, right? But remember, transferrin saturation is decreased in both iron deficiency anemia and anemia of chronic disease, because this is a very, very important point, because many students, they feel that it is increased. So if it is decreased, transferrin saturation is decreased, that is also a finding. If this statement is given, decreased is a true statement, right? And TIBC is decreased, as already I have told you, so that is also a true statement. So here we can see there are two answers which are right. right? So now you got it. So I will just sum it up. What happens in anemia of chronic disease? Because of chronic inflammation, macrophage will be activated, cytokines will be released, and they will start activating increased synthesis of hepcidin and inhibition and decrease in the colony forming unit erythroid series. As a result, what we are going to see an anemia of chronic disease lab finding, I will again sum it up. So as I said, serum ferritin level will be high because of the storage iron will be high. So transferrin will be low, total iron binding capacity will be low, and percentage saturation of transferrin will be also decreased. Hepcidin level will be increased, right? So that is what I have to tell that. Please remember this lab finding, and specifically I would like to emphasize, please see the Harrison table. You will find that percentage saturation of transferrin is decreased in anemia of chronic disease. It is not increased, and it is also decreased in iron deficiency anemia. Please remember, this will be also same for iron deficiency anemia, will also have decreased. Only difference that there will be more decrease in percentage saturation of transferrin in case of iron deficiency anemia. That's all. Otherwise you will not find anything. Both will be, so that is what I want to make it very simple. Both iron deficiency anemia and anemia of chronic disease and anemia of chronic disease will be having same finding, right? They will be having same finding when we will talk about percentage saturation of transferrin, that will be decreased, right? So TIBC decreased, and this is the right answer which was given in this particular question. Now coming to the one of the very important question which has become controversial because people, they have tendency not to follow the textbooks. Please remember, if you go through the Harrison and Robbins, you will find that ratio of T and B cell. In my classes also I used to tell that, right? It is a 4:1. I used to say that T cell are approximately 70 to 80% and B cells are approximately 20%. So please remember, if you say that it is 10 to 20% and you take out average value, what is 70 to 150, so it is coming 75. Right, average value of 10 to 20 is coming 30, 15. So how much it is this? Is it 3:1 or 4:1? So please remember, it will be 4:1, right? So remember, this will be right answer. I have just written it wrongly. It should be 3:1 and like that. So please remember, it should be 4:1 and answer should be this one. And I have taken the reference of Harrison also. You can see 2467 page number of Harrison, 20th edition, where it has been mentioned. You can see the T cells. This is the screenshot of the Harrison, where you can see in mature T lymphocyte constitutes 70 to 80% of the normal peripheral blood. I will just use normal peripheral blood lymphocyte. This is the 70 to 80%. And on the other hand, 2469 page number, these are the two page number, you can see mature B cells are 10 to 15% of the human peripheral blood. So now you understand why I am saying answer should be 4:1. Same is given in Robbins also. See Robbins page number 195, and you can see here it is mentioned T lymphocytes, they are 60 to 70% of the lymphocytes, right, in the blood. Whereas B lymphocytes, you can see 10 to 20% of the lymphocytes. So again, it is 4:1. So please remember, answer should be 4:1. Right? In blood bank, donor blood screening is done for all of the following except. So this is again a very simple question. Hepatitis B and hepatitis C, we do. Malaria, we do screening. HIV, you remember both HIV-1 and HIV-2 screening is done in the blood bank all over world, not only in India, all over world, because this was also question in the earlier NEET PG exam. HIV, which HIV is screened, 1 or 2 or both? So both HIV-1 and 2 will be screened, but dengue screening is not done in our blood bank. So this is the right answer. Answer is D for this 12 number question. Coming to the next question, neurosecretory granule. Also in my classes I have told you, neurosecretory granule is a marker of neuroendocrine tumor, and they will be also known by a name called as dense core granule. Dense core granule was an image based question in AIMS 2020. So that's what I wanted to share. That topic will be repeated. So what are the endocrine tumors? Where it will be seen: medullary carcinoma, pituitary neuroendocrine tumor, paraganglioma. But adrenal cortical tumor, they are not neuroendocrine tumor. Cortical tumor will be arising from the cortex cells, right? Not neuroendocrine tumor. So this should be the right answer. So medullary carcinoma of thyroid, pituitary, paraganglioma, all will be having neurosecretory granule, right? So Now coming to the next question, again a very easy question in exam, in my classes also we have discussed. These are some straightforward question where you need not to read the other options also. When you look at the lymphocyte, you can understand this is not the part of innate immunity, right? So all the T lymphocyte, B lymphocyte, they are not part of innate immunity, right? So that's the answer. Alpha defensin, where is alpha defensin present? They are present in the neutrophilic granules, right? So neutrophil is a part of innate immunity, right? Question is about who is not a part of innate immunity. Gamma delta lymphocytes, T lymphocyte was again a question in earlier in exam, I think in AIMS 2019, right? So this was the question. So gamma delta T lymphocytes, they are also associated with innate because they are having no association with CD4 or CD8 receptors. So that is again a very, very important thing. And their behavior is like a antigen presenting cell. So antigen presenting cell like function is present, which is also a innate immunity part. So this is also innate immunity part. Lectin pathway is associated with complements, and this is again a part of innate immunity. So answer is B. So there is no doubt in this. Now this question, I have got two information. One key, what is this? So if question is like this, so there is no doubt this is the fish technique. But there was another question which I will discuss in question number 28. Probably that would have been an ideal question. I think AIMS people will not be asking this kind of blunt and useless question. So I'm just coming to the next question. Next question is about a 16-year-old boy, tibial diaphysis lesion. Histopathological examination is given below, and it was MIC2 positive, synaptophysin positive. Most likely diagnosis will be. See this diaphyseal lesion, right? MIC2 positive and synaptophysin positive. See, MIC2 positivity is a very good hint, right? See here, hint, what are the hints? 16-year-old boy, right? Tibial diaphysis, MIC2 positive, synaptophysin positive tumor cells. And then you are seeing the histopathological examination like this. So these are the things which we have to consider, because MIC2, if I will say that MIC2 or CD99, it is usually positive in which cancer? It is seen in Ewing sarcoma, right? So this is seen in Ewing sarcoma. So answer should be Ewing sarcoma, because Ewing sarcoma is also considered as a part of primitive neuroectodermal tumor, and that is why they are positive for synaptophysin, which is a marker of neuroendocrine tumor, because it is not very sure what is the correct origin, but they have clubbed into their neuroendocrine tumor. So that is why Ewing sarcoma will be having marker for the neuroendocrine tumor also, which is a primitive neuroectodermal tumor. So synaptophysin will be also positive, MIC2 also positive, young patient. And what we are seeing in the microscopy, you can notice there is a area which is showing you a rosette. So this is the pseudo rosette, Homer right pseudo rosettes. So we are seeing Homer right pseudo rosettes, right? So Homer right pseudo rosettes are also present in this, and you can notice these are having a small round blue cell tumor, right? So these are a small round blue cell tumor. So small round blue cell tumor, Homer right pseudo rosette, this kind of presentation, this kind of the marker positivity is in favor of the Ewing sarcoma, right? So now we will go with the Ewing sarcoma, and what are the finding? You will see small round blue cell tumor, clear cytoplasm. In this picture it is clear cytoplasm is seen, and clear cytoplasm is because of glycogen. So please remember, examiner can ask you this question: glycogen containing bone tumor is Ewing sarcoma, right? And Homer right pseudo rosette, so you can see there is a neural tissue and tumor cells are surrounding them. So this is the neural differentiation, right? So neural differentiation is shown by Homer right pseudo rosette, which is seen in Ewing sarcoma. In osteosarcoma, what you will see? Fine lace like pattern of neoplastic tumor cells. You will see these are lace like, fine lace like tumor cells are there. So these are the formation of bone by mesenchymal tumor cell, and that is diagnostic finding, right? And in Jan cell tumor, which is also called as osteoclastoma, if this was the option in your exam, again a very important question which examiner ask in exam. So osteoclastoma, what are the findings you are going to see? This is the same name, right? They will have two component, tumor cells and non-tumor cells. So how will be the tumor cells? They are uniform mononuclear oval cells. So all these uniform mononuclear tumor cells are there, and non-tumor cells are multinucleated Jan cell, which are actually osteoclast type of Jan cell. So this will be osteoclastoma. So in this we are not seeing any Jan cell or fine lacy fungal, hyphae like bony things. So that is why we are ruling out osteosarcoma and Ewing sarcoma and giant cell tumor. Now next question is MSC1. This is again a very simple and basic question which examiner had asked. MSC1 will present antigen to, MSC1 will present to cytotoxic T cells, right? X-linked dominant is an older NEET question. In 2016 this question came, and it is associated with Rett syndrome. X-linked dominance is seen in Rett syndrome. G6PD deficiency anemia is X-linked recessive disorder. Tuberous sclerosis is autosomal dominant. Sickle cell anemia is autosomal recessive. If all these options were like this, so answer is Rett syndrome. Right. Next question is, which of the following is correct match? That is again a very good question. Teratoma, lymphocytic infiltrate, dysgerminoma, neuroepithelium, yolk sac tumor. So now these are the options. So first of all, we all know that what should be the right answer in teratoma. So now we will analyze one by one. Teratoma is, will you find lymphocytic infiltrate into them, or you will find neuroepithelium, hair and cartilage? So we will see this one, right? That's true. Now we will see what we will see, dysgerminoma. Dysgerminoma, if you remember, I have shown in exam also, in my classes also, that they will be having a tumor cells which will be having a nest or sheet surrounded by the fibrous tissue, and they will be having lymphocytic infiltration. So dysgerminoma may have lymphocytic infiltrate. So this will be for dysgerminoma. Yolk sac tumor will be having Schiller dual bodies, and granulosa cell tumor will be having Kohl-Exner bodies. So this is the right answer. So A is 2, B is 1, B is 1, C will be 4, and D is 3, So I think A option is the correct answer, right? So this is the correct answer for this, right? Now coming to the next question, a 38-year-old female presented with fatigability and dyspnea on exertion with such a low hemoglobin 6 gram%, what will be most likely finding on peripheral, right? So this picture is quite non-specific, but it will be highly suggestive of iron deficiency anemia. And iron deficiency anemia, you will be seeing microcytic and hypochromic peripheral blood finding. So that is a very simple question, right? All of the following are caused by lethal strains of human papillomavirus. In my lecture also, I have discussed this very detailed, that there are two strains, 6 and 11, 16 and 18. 6 and 11 is associated with benign papilloma. Those who have attended my lecture, they remember it very well, right? Benign papilloma. And 16, 18 are associated with carcinoma, right? So this carcinoma can be nasopharyngeal carcinoma, this can be oral cancer also, this can be cervical cancer also, right? So these are the important point you have to remember. So you can see cervical cancer, oral cancer, anorectal cancer, and laryngeal papilloma. Lethal means which will be causing cancer. So these are lethal, and laryngeal carcinoma is non-lethal. So this is laryngeal papillomatosis, right? So this is the papilloma or papillomatosis, which is a benign kind of lesion. So that is not lethal, right? So that is why answer should be this one, right? Answer should be D. Now coming to the next question, during pregnancy, which of the following coagulation factor is decreased? So remember, during pregnancy, only one coagulation factor is decreases, that is factor 11. So this is the right answer. What I will suggest you here, just to remember this table which I have given you here. So most of the blood coagulation factor, including fibrinogen, will increase during pregnancy. Please remember, they will increase during pregnancy, but factor 11, you have to remember, factor 11 is the only blood factor which will decrease. Remember, blood coagulation inhibitors, when we talk about blood coagulation inhibitors, right, they will be unchanged, but free protein S will decrease. So protein S will decrease. You can see in this table also, I will just mark it. What are the important thing? 11 is reduced, which was the question in this exam. Future question can be protein S will be also reduced. Protein C, but protein C, antithrombin 3, they will be unchanged. That is the important point you have to remember, right? D dimer will be increased, plasminogen will be increased, all the other factors are increased. Factor 2 will be also unchanged. Please remember, factor 2 is also unchanged in the pregnancy, right? Now coming to ectopic tissue of the Meckel's diverticulum, we all know that most commonly it will be having gastric and pancreatic tissue. So that is the right answer, right? So please remember, ectopic tissue is approximately 50% of the cases they will be having gastric tissue, and 60 to 85% cases, right? 60 to 85% they are gastric tissue. So I repeat. Please remember, gastric tissue is present in 65 to 85%, and pancreatic tissue is only 5 to 16%. So what I want to say that if in future examiner ask you what will be more commonly seen, so please remember this is how tendency of examiner. So gastric tissue is more commoner than pancreatic tissue in the Meckel's diverticle, right? Which of the following banding technique is used for dicentric chromosomes? So for any chromosome karyotyping, right, G banding is most commonly used because this G is also known as GIMSA stain. So please remember GIMSA is the most common and best stain for karyotyping also. So this question can be again repeated in your NEET PG exam. So please remember this also, right? This is the most common and the best stain. So if examiner asks you which is most common or which is best stain for karyotyping, answer will be GIMSA, and that is the basis of the name G. G stands for GIMSA staining, right? Which of the following is not seen in pleomorphic adenoma? This question is little tough one because I never used to discuss all these salivary gland tumor, but now I'm thinking to include in my lecture also. So I am going to tell you about in this. This is a very simple question. If you ask me, it's a very simple question. As a pathologist, I will tell you they will have myoepithelial cell. It's a mixed tumor. They will have chondrite differentiation. They will have keratin pulse. Many people they think that keratin pulse are not there. Keratin pulse are seen when they will have squamous metaplasia into the tumor mass, right? So squamous metaplasia will be present. See, this is a pleomorphic adenoma. Question is, I would like to draw your attention. Pleomorphic adenoma is a benign tumor, right? Pleomorphic adenoma is a benign tumor. So they should have a benign finding, right? But when we talk about perineural invasion, perineural invasion is not seen in benign tumor. This will be seen in carcinoma X pleomorphic adenoma. So that is why this should be the right answer, right? Chondrite differentiated myoepithelial cell, all will be seen. I will show you the diagram also. See, these are the pictures of the pleomorphic adenoma. I have written all the description. So there are three components. Epithelial cells, so you can see epithelial cells are the ductal cells, right? Myoepithelial cells are again scattered round single cells which are round to oval to stellate cells can be present. And now you can see that myxoid means blue pink mixture will be there. So this chondromyxoid stroma you can see here, these are all chondromyxoid stroma. These single cells which we are seeing, these are myoepithelial cells, ductal cells, and metaplastic changes can be seen like a squamous metaplasia. I will show you. So now you can see these are the again squamous metaplasia of the pleomorphic adenoma where we are seeing keratin pulse. So now in this picture you can notice what I'm marking. These are two important keratin pulse which we are seeing in the pleomorphic adenoma. This is the part of squamous metaplasia, right? So these are part of squamous metaplasia. So that's what I said. Pleomorphic adenoma can have keratin pulse. And remember, when they have a perineural invasion, so this is the neural bundle, right? This is the neural bundle and tumor cells are infiltrating here. Tumor cells are infiltrating here. So this is called perineural invasion. So whenever we find perineural invasion, that is the finding of carcinoma X pleomorphic adenoma. So this should be the right answer for this one, right? Now coming to the next question, which of the following is correct match between the gene mutation and their tumor? So this is again we have discussed in class. See, if you know 2 or 3 things in the correct match of the these things, so you can easily make out the correct answer. For example, if I don't know about the plaque, right? So I'm not knowing about this. You might be not knowing about all these things. So you can easily make out because we all know that anemic amplification is for neuroblastoma, right? C-MYC, come to the C-MYC. C-MYC is for C-MYC translocation is for Burkitt lymphoma, right? And RB gene is for retinoblastoma. So what is plaque? Plaque is for pleomorphic adenoma. So it's easy. So now you can see that A is for 4. So A is for 4. B plaque is for 1. B is for 1. C-MYC is for 2, Burkitt lymphoma. And D is RB gene for retinoblastoma. So answer is A. So that is how you can solve these kind of questions. So right. So answer is A. Now familial inheritance is seen in, this is again a very important question in my classes also. I have discussed that retinoblastoma, retinitis pigmentosa, they are all familial. Acute angle closure glaucoma, myopia, all 4 are familial in inheritance. So answer will be all 4, right? So here I have given some references also, because some may object also, right? So familial pattern of inheritance are well established in familial high myopia, and you can see this is the journal of the Nature, where you can see this link. You can click. I will share this PDF in my Telegram group, and then you can click on this link, and then you can see the image also, right? And primary angle closure glaucoma is also one of the important thing, which will be having genetic factor and familial association. So answer will be all of the above. So this was the question which I was telling you, that fish study of the Ewing sarcoma is shown below. What does the marked area represent? So you can see this is how I have got the information from one of my students, that he said like this, okay, sir, question was like this only. They have given arrow like this, and they had asked what is the marked area represent, right? So marked area here, see, this area is a fusion, right? This fusion area is the normal area. Please remember, this is the normal area, and this is the split area, and this is the Ewing sarcoma region 1. A split area is the region where fish is showing EWSR1 rearrangement, which is suggestive of the tumor. So answer should be B. So this will be the right answer. So what I am showing you here, this is the split region. So see this picture, right? Answer is fish showing the rearrangement of EWSR1 gene. So this is the fluorescent fish analysis, and a special type of fish analysis which is called as dual color break apart probe. So remember, this is called as dual color break apart fish, right? So dual color break apart fish, what we will see, normal pattern will be consisting of fusion of the orange and green signal. So that's what I have said. Okay, when you are going to see, this is the normal pattern, right? This is the normal pattern where you are seeing the fusion of gene, orange and red color, right? But when you are seeing the rearrangement of, right, so again I will show you, when you are seeing the rearrangement of EWSR1, there will be the split of the fusion signal into the red area and the green area. So now you can see there is a split of the red and green area. So this area, red area, is the centromeric area, and green area is telomeric area, right? And this is showing rearrangement of, this is the answer, right? So that is the right answer if question had been asked like this. Which one of the following is true about autophagy? This is again a very simple question, right? In classes we have discussed, right? They are not single layered, they are double layered. So this is a wrong, right? So they are double layered. So this is the wrong statement. It occurs when there is an increase in protein inside cell. So it is not increase in protein, it is a gene regulated. So as we know that many genes are associated. One of the important gene which I used to teach in my classes, or like ATGS5 gene, is also associated with them, right? Fuse with all type of organelle. No, it is not fusing with all type of organelle. It will only fuse with lysosome. So autophagosome will fuse with lysosome. Autophagosome will fuse with lysosome, and this will form autophagolysosome. So this is the correct answer. So D is the correct answer for this question, right? Coming to the next question is, which of the following is example of partial aneuploidy, right? So we have to understand partial aneuploidy is Cry-du-Chet syndrome. Weger syndrome is disorder where you will not see the partial aneuploidy. I will explain you what is partial aneuploidy. And congenital adrenal hyperplasia is autosomal recessive disorder. Testicular feminization is the X-linked disorder. So these are all having a complete damage or complete mutation or complete genetic changes. They are not having partial changes, because in Cry-du-Chet syndrome there is a 5p deletion. But remember, in this 5 short arm of the chromosome, it is not fully deleted, so it is partially deleted. So that is why sometimes we also call this as a partial monosomy or partial aneuploidy. So it is very important to understand this important point. Partial aneuploidy is also known as partial monosomy or partial trisomy, right? It is an imbalance of genetic material caused by, remember what is this, caused by loss or gain of part of chromosome. So it can be loss also or gain. So in this Cry-du-Chet syndrome, you will remember 5p deletion is there. So there is a loss of the gene, right? So Cry-du-Chet syndrome is a partial deletion. So it is a partial monosomy or partial aneuploidy, right? Weger syndrome is micro deletion of the 11p13. So this is not the, it's a micro deletion. It is not the partial loss, right? So that is the very important thing. So this is the micro deletion, not a partial aneuploidy. Congenital adrenal hyperplasia is autosomal recessive. Testicular feminization, I already have told, this is the X-linked disorder. So coming to the next question, again it's a repeat question. In my classes I have taught you very well about this clear cell RCC, right? And in a high yielding short also few days back I have shared in my Instagram, and that have been discussed. You can go and you can see few days back, just few days back, 5 or 6 days back, I have shared about the clear cell sarcoma, clear cell carcinomas. So in clear cell carcinoma you can see what are the findings you are going to observe. Mostly sporadic, so this is a true statement. So examiner is asking which is true about clear cell type of RCC, right? So it is a sporadic mostly. It is a due to deletion of 3q. No, it's not 3q deletion. It is a 3p deletion, which is a von Hippel-Lindau syndrome gene deletion. Vacuoles contain both lipid and glycogen. In my classes I always used to say that they will be having both lipid and glycogen, right? Originating from the DCT, so it is not from the DCT, it is from the proximal convoluted tubule, right? So overall we are seeing two statements are correct. Mostly sporadic and vacuoles contain lipid and glycogen. So what should be right answer? Answer should be B, 1 and 3, right? So you can see clear cell RCC is the most common type of RCC. Origin is from the proximal convoluted tubule. This is how I have taught you in classes also. Microscopy, they will be having vacuolated cytoplasm which will be containing glycogen and lipid both, and chromosomal abnormality 3p deletion is the most common deletion. So it is 3p deletion which will be seen in clear cell RCC, right? This was the question which examiner had asked in exam. I did not get proper history, ovarian tumor histopathology, and if this was the picture, so probably it is a yolk sac tumor, right? So it's a Schiller dual bodies, right? So it's a Schiller dual bodies which we are seeing in yolk sac tumor, right? Teratoma, you will be having other things also like adipose tissues, smooth muscles, hair follicles, all these things will be seen. Dysgerminoma, I will discuss all that thing also, right? So it's a Schiller dual bodies. What is Schiller dual bodies? Schiller dual bodies, what you will observe, centrally there will be a blood vessel, right? So how you will identify blood vessel? There are RBCs within the lumen. So centrally there is a blood vessel. Then they are covered by tumor cells. So central blood vessel covered by tumor cells. So I have written here. You can see there is a central blood vessel. Then they are covered by tumor cells, right? Covered by tumor cells. Then they are again enclosed. See, this is the empty space. So this is the cystic space, and cystic space is again covered by tumor cell. So this is the description of the Schiller dual bodies which you see in the yolk sac tumor. So what is Schiller dual body? Central blood vessel covered by tumor cell, right, which is enclosed inside a cystic space and again covered by tumor cell. So that is how you can remember, right? So central blood vessel, as I said, covered by tumor cell. This is enclosed inside a cystic space which is again covered by tumor cell. So again you can see in this picture also of the yolk sac tumor, you can notice what is this? What is this? Blood vessel, right? And what are these things? As I said, blood vessels are covered by tumor cells and surrounded by empty space. What is this? This is a cystic space, and again cystic space is covered by tumor cell. So that's what I have told you now. Blood vessel is covered by tumor cell which is enclosed inside a cystic cavity and which is covered by tumor cell. So this is the picture of Schiller dual bodies seen in yolk sac tumor, right? So yolk sac tumor, please remember some extra point for upcoming NEET PG exam. They are alpha fetoprotein positive, and remember this will be having maximum elevation amongst the all non-seminomatous condition. And apart from this, they will be also positive for alpha 1 antitrypsin. Please mark this. These are the questions which had been asked very, very frequently in NEET PG and DNB exam. So alpha 1 antitrypsin is also a tumor marker for yolk sac tumor. So there are two tumor markers I have given you here. One is alpha fetoprotein, second is alpha 1 antitrypsin, right? In granulosa cell tumor, what we are going to see, it's a ovarian tumor. So they will be having a spindle cell tumor. You can see all these are spindle tumor cells with elongated nuclei, right? When you will see all these tumor cells, they will be having elongated nuclei, and elongated nuclei will be having grooving. So they will be having grooving, which is also called as coffee bean appearance. So that is also question in exam. Coffee bean nuclear grooving is seen in Which ovarian tumor? The answer should be granulosa cell tumor, right? And you can notice a very interesting thing: centrally eosinophilic area surrounded by tumor. So this is again a pseudo rosette, and these pseudo rosettes are called as Call-Exner bodies. So Call-Exner bodies, they're not diagnostic, but they are characteristic of granulosa cell tumor of the ovary, right? So three finding. What are the three finding? Is spindle cell tumor, nuclear grooving, Call-Exner bodies. If you find, then it is a granulosa cell tumor, right? As I have told you, dysgerminoma, you are having sheets and nests of the tumor cells, and you can see the lymphocytic infiltrate. That's what I was telling you in that question also. Okay, they will have a lymphocytic infiltrate, right? Stroma contains lymphocytes, right? And in teratoma, you can see they will be having glands. You can see these are the glands, right? You can see the ectodermal origin keratin is present, right? And you can notice there are areas of the smooth muscles. So these are the areas of the smooth muscles, and this one, the most important one, this is showing you the cartilage also. So when you have these kind of thing, then you can think about teratoma, right? Which of the following will be chronic hepatitis B serology? So this is again a very good question which I have discussed in my app lecture, right? So if you see my app, in my app I have discussed. So there are four things which examiner had given here. One is the HBsAg, second is anti-HBsAg level, third is anti-HBc IgG, and fourth is HBV DNA. And examiner is asking about which will be the feature of chronic hepatitis B serology, right? So in chronic hepatitis B serology, I will just say like this: HBsAg should be positive. I'll not write here, otherwise you will be getting confused. I'm writing here, right? HBsAg should be positive, right? Anti-HBsAg, see, anti-HBsAg will be negative, because if it is positive, it means the person has been vaccinated and cured. So it is not possible, right? So it is not possible. It should be negative. But HB, IgG, HBC, IgG, HBC is ongoing infections, which is ongoing infections or chronic infections. So that is why this will be present. So this will be present, right? HBV DNA is a sign of replication. So definitely if it is a chronicity going on, so they might be replicating fast also. So HBV DNA will be also positive. So this should be the presentation of this case, right? So now understand. So what I'm saying here: HBsAg positive, anti-HBs negative, IgG HBs positive, and HBV DNA positive. So answer should be A. So this is the first option, which is the correct answer for this question, right? I will give you this PDF. So this serology you can go through once, right? What I have shown you here, I'll just briefly tell you. HBsAg more than 6 months, it can be seen in chronic, right? Anti-HBsAg is active or passive immunization, and they are protected. So it is not seen in the chronic hepatitis B, right? When we see anti-HBC antigen, so IgM is for the acute infection, but IgG is the previous or ongoing infection. So that is the three things which we are seeing in this question, right? Number one, HBsAg is positive. Number two, this will be HBsAg is positive, anti-HBsAg is negative, right? Anti-HBC antigen IgG will be positive, right? And the viral replication marker, two markers are HBeAg, which is qualitative marker, and quantitative is HBV DNA. So this will be positive because they are proliferating faster. So that is how you can solve this question. Cell in cell appearance, this is again a little atypical question, which is examiner had asked. But if you have attended my lecture, you can easily understand I have never said cell in cell appearance for apoptosis, necrosis, necroptosis. So you can rule out and you can come to the answer called antosis, right? So this is the antosis. What is antosis? Antosis means Greek word which means inside or within. What we will see here, invasion of one cell into the another cell, which will be requiring the adhesion molecule, contractile protein like actin, myosin, and lots of energy in the form of Rho and ROC, right? So what will happen in this? Matrix will detach and adhesion junction will be formed. See, this is the basement membrane and these are the two cells, right? So matrix detachment is the crucial part of the entosis, right? So this is the most important part of the entosis, matrix detachment, right? Which will allow this adhesion molecule to form. So now you can see each adenine adhesion molecule has been formed. Then Rho ROC mediated contraction will happen, and this cell will start contracting and they will move inside the another cell, and that is how cell in cell will be formed, which is entosis, right? So cell in cell entosis, how it differs from the emperipolysis. Emperipolysis, they will only survive, but here they will have a death also, right? So internal cell, they may undergo death also in case of entosis. That is the point we have to remember. Now this is again a very simple question, already I have discussed in my lecture so many times. Differential expression of the genetic material, or otherwise we have learned like this: functional allele is inherited from one parent only, right? So this is called as genomic imprinting. Genomic imprinting, right? So that's what I wanted to say, that differential expression means one parent. See, for one allele, I will just show you so that you can understand. Suppose I am showing you these are the two chromosomes, right? So this is the paternal, this is the maternal chromosome, right? Every gene, suppose I am writing a gene, they are having two allele. One is paternal allele, one is maternal allele, right? So these are the two alleles. What I'm showing you, paternal allele, this is the maternal allele. So what is the meaning of differential expression? Means one of them is inactivated, imprinted. So in this picture I'm showing you maternal is inactivated, right? So who is functional? Only paternal is. So this is called differential expression. Means we are seeing one gene, but they are having two different alleles and their expression is different. One parent maternal is imprinted, paternal is functional. So this is seen in genomic imprinting, right? This is seen in genomic imprinting. So right answer is B, right? So that is how you can solve this question. And I will tell that if many questions came from my app, and I can vouch for that more than 25 question came from my app lecture and from my book. If you see my book, there are more than 30 question came, right? So I have discussed here. So I will just suggest you follow my this Telegram group and subscribe my app also and see those lectures, which will be definitely helpful for second year as well as those who are preparing for FMG, NEET, PG, INICET, whatever exam, right? So keep revising for your NEET PG exam, which is after 7 days or 10 days. So please remember, many questions can come from these topics which I had discussed. So please remember, I am not saying this question will be repeated. These topics can come in your exam. So keep revising these topics from your notes, from my app or from my lecture, and stay positive and stay confident before your exam. So don't lose hope at any time. How was your INICET exam? What will be your rank? Doesn't matter. So don't get affected by the result of INICET if it is not in favor of yours, right? Keep moving on. Don't have any kind of thought block because of these results. So my best wishes to all of you, and I hope you will be all having great and grand success in your exam. Bye.